Good afternoon, everyone. My name is Dr. Pooja Shah. I'm a senior resident from Dr. RP Center, and I'm a ratified AIOS member, and my number is S18504. I will be presenting the study titled Cost Effectiveness Analysis of Decimet Stripping Automated Endothelial Keratoplasty versus Penetrating Keratoplasty in Patients with Corneal Endothelial Dysfunction. And my study was done under the guidance of Professor Radhika Tandon, Professor Vanati, and Professor Nupur Gupta from RP Center. So endothelial keratoplasty is the mainstay of treatment for patients with endothelial dysfunction. There are several clinical advantages over penetrating keratoplasty, and they have been studied in various studies. However, this clinical efficacy and visual outcomes are well documented, but the efficiency of DSEC with an economic evaluation is underreported. And economic evaluation basically means outcomes and costs of intervention are compared in order to improve the allocation of resources. So amongst the various types of economic evaluations, we decided to do a cost effectiveness analysis in which the outcomes of interest are measured in natural units, and a cost utility analysis in which the outcome is the improvement in outcome is compared to improvement in quality adjusted life years or health years. And the perspective of evaluation in our study was from the patient's perspective. Consecutive 120 patients were selected, 16 each group, who met the inclusion criteria and were not fulfilling the exclusion criteria. The visual, the outcome, the effect was measured in terms of visual acuity in logMAR units, and the total cost incurred by the patient was captured under the following headings, like the cost of initial surgery, cost of visit to hospital for follow-up, and cost of treatment in the form of medicines, and the cost for any procedure incurred for any complication, and the cost of refractive rehabilitation. Baseline characteristics of the two groups were compared, and any differences were adjusted statistically, which mainly included the length of the follow-up, the distance traveled by the patient for follow-up, and the preoperative visual acuity, which was important because patients undergoing PK had poor initial visual acuity, and this had to be adjusted. So the gain in visual acuity is as follows at 6 months, 1 year, and 2 years. And it is seen that the gain in visual acuity is more in patients with DSEC, which is statistically significant at all 3 time points. But once we adjust the preoperative baseline visual acuity in the two groups, the difference at 2 years was not statistically significant. The total cost captured were in the range of so-and-so at the baseline, at 6 months, at 12 months, and at 2 years. And at 6 months, the cost incurred by the patients undergoing DSEC was more, which was statistically significant. And at 2 years, the cost incurred by the patients undergoing PK was more, and that was also statistically significant. Next, we calculated the incremental cost effectiveness ratio, which is a ratio of difference in cost of intervention over the difference in the effect of the intervention. And in our patients, the incremental cost effectiveness ratio, which basically means the cost of improvement of 1 logMAR of visual acuity, was 39,000. And the cost incurred by the patients undergoing PK was more. Then we did an incremental cost utility analysis in which the gain in visual acuity was converted to a utility value, which is a surrogate marker for improvement in health adjusted quality of life, quality adjusted life years. And the incremental cost utility ratio at 2 years was, for PK being costly, was 1,95,000. So for improvement of 1 quality adjusted life year, PK was 1 lakh times more costly than DSEC. Now, as per the WHO choice initiative, which is for choosing a cost-effective intervention, if an intervention improves 1 quality adjusted life year, and the cost for that intervention is ranging from 1 to 3 times the gross domestic product per capita, then that intervention is termed as deemed as cost-effective. So in our study, this falls less than 2 times the GDP, so it is cost-effective. DSEC is more cost-effective than PK. So then at 2 years, from a patient's perspective, at a tertiary care hospital with a subsidized treatment, at a willingness to pay threshold of 2 times the current per capita gross domestic product. Now, points in favor of my study is that this is the first in time economic evaluation of keratoplasty patients in Indian setup, and limitations of my study would include that this is not generalizable because it is a single center outcomes which we are reporting. However, if we do multiple such studies, we can actually promote more training and capacity building for DSEC. Thank you.